wrist arthroplasty biomechanics. Then in the first section of my talk, I show you how the wrist bones or carpal bones move together, and I discuss a predictive mathematical model for their motion. This is important because total wrist arthroplasty designs basically replace all of the carpal bones with only one joint. In the second section of my talk, I study the total wrist arthroplasty, and I do it in an in vivo experiment by looking at 3 primary outcome measures. And then I wrap up with some of the main limitations of our work and possible avenues for future work. So let's dive in. So how does the wrist actually move? We know that the wrist motion mainly takes place in 2 directions: flexion, extension, or up and down movement, which is in the sagittal plane of the wrist, and radial ulnar deviation, the side movement of the wrist. These are called the anatomical axis. And underneath the skin, there are 15 bones. And based on previous studies, the overall wrist motion can be described as the motion of one of these bones, shown in purple, third metacarpal, relative to the radius, shown in red in the figure. Anatomical axes are important, but the wrist motion during occupational and household activities, like hammering or pouring water in a cup, is aligned with a combination of these axes. This oblique axis is named the functional axis of the wrist, or dart thrower's path. And it can cover the largest magnitude of the range of motion, and it goes from radial extension to ulnar flexion. So let's look at the wrist joint on a deeper level and the 8 small carpal bones that it has. And also, let's do an experiment with me, which I often find it useful for those who are not studying wrist as I do every day. So I want you to look at your hand and try to understand the scale of these bones. These are 8 tiny bones, and actually one of them is really easy to identify. If you just put your left thumb underneath your right thumb and move your wrist to the side, you can feel one of these bones pushing against your left thumb. This is the scaphoid bone, or the pinkish color bone shown here. And keep in mind that all of these bones move together to allow the efficient and stable positioning of the hand. And also, because there are only minimal direct tendon and muscular insertions to the carpal bones, the wrist motion is mostly passive, and it's based on the ligamentous constraint and the compression forces from the distal structure. So overall, when we are young, our wrist works great, and it can handle a wide variety of tasks. But when there is a severe injury to the carpal bones, or there is a presence of osteoarthritis due to aging or other factors, these bones lose their shape and the cartilage between them degenerates. So patients feel pain and they cannot move their wrist easily. One of the solutions is using, using a total wrist arthroplasty, or TWA. And TWA's objective is to reduce the pain and restore the function of the wrist. At the bottom, you see 3 of the currently approved TWA designs that try to mimic the wrist joint artificially. In TWA surgery, the proximal row of the carpal bones will be removed, and the capitate will be resected, and the TWA replaces all of those bones. And the latest generation of total wrist arthroplasty systems have 3 main components: a radial component, which goes inside the radius, the carpal component, and polyethylene cap that they create the artificial joint. The movement of polyethylene cap on the radial component aims to mimic the wrist movement. Unfortunately, though, TWA designs suffer from a high complication rate of more than 25–30%, even just after 5 or 6 years. And complications such as loosening or osteolysis can lead to a later failure of the implant, which means if we reduce these complications, we can improve the survival outcomes and have happier patients. So the knee and hip arthroplasties have been studied biomechanically in various conditions. However, the TWA designs have been empirical and by trial and error mostly, because the joint is complicated to study and there are many factors that are involved in wrist movement. And the current designs, total wrist arthroplasty designs, assume that the joint is an ellipsoidal shape, and they have helped patients greatly, but as I showed, they still have high complication rates. Hip and knee joint databases have suggested implants that simulate the natural healthy joint movement can reduce the complication rates and increase the survival rate of the implant. But such databases don't exist for the total wrist arthroplasty. So my main objective was to study the biomechanics of wrist and total wrist arthroplasty and understand how does this implant move in vivo. First, because everyone assumes these bones can be replaced by only one joint, I wanted to test this assumption in vivo. And we had a large database in our lab, which was all over the place in our servers. So I used that to evaluate this assumption and create a mathematical model for it. After checking the assumption, I designed an in vivo experiment to look at the overall wrist motion of the wrist and total wrist arthroplasty. And I decided to specifically look at the center of rotation, role of alignment of the components, and the contact pattern of the components. So because as we talked about, the wrist is a passive joint, we believe the wrist motion is driving the carpal bones movement. So in this section, we wanted to test that. And we assembled a large database of carpal bone kinematics. Then we developed a model that predicts the motion of carpal bones relative to the wrist motion. And lastly, we used the model to determine what does it tell us about the wrist paths that result in the minimal movement for the carpal bones. Basically, we wanted to see what's the main relationship between these tiny bones, between these tiny carpal bones. Previous literature has come up with two main theories about how this carpal joint functions based on the in vitro studies mostly. So first is the row theory, which you see on the left, which organizes the carpus or wrist into proximal and distal rows. And it states that wrist flexion and extension occur between the two rows, while the wrist radial and ulnar deviation primarily occurs at the articulation of the scaphoid. The other theory is the column theory, which organizes the carpal bones into radial, central, and ulnar column. And it states that the wrist flexion and extension mainly takes place in the central column, and wrist radial ulnar deviation is the rotation about that column. So to check this in vivo, I assembled a large database of carpal bone kinematics that our team has acquired in the last 20 years. And our database has 120 studied wrists for 90 subjects, and it has about 1,200 wrist postures. The database, excluding the CT scans, is uploaded on the SimTK website. Briefly about our database, we have a well-established protocol for the data acquisition in our lab. We ask subjects to hold their wrists in predefined postures while in the CT machine. We get the CT scans, we segment their carpal bones in the neutral posture, and using a tissue classified registration algorithm, we find a motion between the neutral pose and each task. To look at the motions, we define carpal bone kinematics in the radius coordinate system, and you can see the definition of rotational components in the image on the radius. And also all translations were scaled based on the capitate bone volume. This has been shown to make the translations invariant to the bone size. So all tasks in the database can be shown in a figure that has the wrist radial ulnar deviation on the x-axis and wrist flexion extension on the y-axis. This is the figure on the right that I'm showing you. And the green dot shows the neutral position. And I'm going to show the variation of this figure in the rest of the slides. And keep in mind that this is the figure of wrist motion. Also, every data point that it's here has 42 other dimensions for each bone and each degree of freedom. We only consider 7 bones from the carpal bones because pisiform, one of the carpal bones, is not playing an essential role in the wrist kinematics. So we created independent models for each bone and each degree of freedom. So 42 different models. To get a good prediction at the extremes of motion, we used quadratic surface regression models. And basically, we tried to find each parameter in the equation that I have on the slide. And let me show you what does this equation mean. If we flatten out the figure of all wrist motions and add the z-axis for a bone and the degree of freedom, for example, scaphoid, flexion, extension, we get something like these data points. And a quadratic surface minimizes the least squares differences for all of these points that the equation that is here is showing. we basically are trying to find the best surface that passes through all of these points. Also, to create a predictive model, we held out 3 wrists data, about 260 wrist postures, in order to test our model after we created. And we picked the best training model using Leave-1-Out cross-validation technique, and we evaluate the prediction using R-squared and root mean squared error. Let's look at one of these models, the scaphoid flexion extension. On the left, you see the actual values from the database, and purple is showing scaphoid extension and green is flexion. And on the right, you see the model that we have optimized. If we subtract these 2 models, we get the actual values for the error. And the main purpose of doing this analysis is to make sure that the model is performing consistently all over the database. We have 42 models, and I cannot go over all of the numbers, but in overall, the root mean squared values were less than 6 degrees or 2 millimeters for all degrees of freedom. And the R-squared values were high mostly, but not for the pronation, supination of the bones. And basically for most of them, it didn't work. And this could be because pronation, supination of the wrist was minimal and it's less than 10 degrees in the database. And the other reason could be because the wrist pronation, supination was not one of our predictor parameters. One of the advantages of having a model is that it can help us to look at the patterns and behaviors. And in this talk, let's look at the path that the bone has the minimal rotation or translation. What this means is that when I move my wrist in a certain direction, for example, flexion extension, that specific bone doesn't move in the degree of freedom that I'm going to talk about. So here you see 2 of the models. Prediction for a scaphoid bone is shown on the left, and for hamate is on the right. And white color shows the path that the bone is not moving. The left figure means when the wrist moves in a path oblique to the main wrist axis, a scaphoid does not move in flexion extension. And the right figure means that when the wrist is in flexion extension, hamate does not move in radial ulnar deviation. And so let's look at all of the carpal bones, the 7 bones that we have in different carpal bones flexion extension. So blue shades are showing the proximal row bones and red shades are showing the distal row bones. If we look at the capitate and scaphoid here for the visualization, for capitate in the middle, you see wrist is moving in a path that has minimal capitate flexion extension. As you see, all of the distal row bones have the minimal flexion extension and they move together. For a scaphoid minimal flexion extension, which is the blue on the right bone, you see the proximal row bones are not moving as tight as the distal row, but they still have a similar path. And this model and database shows that the wrist joint is basically composed of 2 rows of bones, and the proximal row on the scaphoid, which is not moving when the wrist moves oblique, and the distal row joints that move along what we call the overall wrist motion. In the literature, as I showed you, this is called the row theory of the joint. And we basically are dividing the wrist joint to radiocarpal and midcarpal joints. In addition to the model, we created a graphical user interface that can be used to teach medical residents how the wrist motion changes the carpal bones posture in various movements. The interface is also capable of loading subject-specific bone models or even other mathematical models. Our model is predictive, and we tested it out on about 260 held out various wrist postures. And we also have created an interface for the model and the database, so it's going to be easy to use for future investigations. And I'd love to talk about it after our research, after our talk, about some of the use cases that people have used the database for. There are some limitations in the modeling, though. There is a room for progressing in model selection, and we did not consider the pronation, supination in the wrist global motion, and that might improve the final mathematical model. Also, collisions between the bones after model prediction was not evaluated in our model, and finite element models will be helpful in evaluating and improving the mathematical model. Probably you have heard the famous quote that all models are wrong, but some are useful. And although our model is not perfect, it is helpful, as I showed, because it not only helps us to understand the carpal mechanics more, it also helps us to transfer the model for future projects like the one that we are collaborating on with Natalia. The advantage of our model is that we basically can design the path of motion and then look at the carpal bone's posture. This helps us to use the model when no actual dynamic movement is available experimentally, which is mostly the case for the wrist biomechanical studies. To conclude this section, we created a predictive model of the wrist motion that relates the global wrist movement to the carpal bone kinematics. And we also used the model and saw different motion patterns for distal and proximal row of carpal bones. TWA designs currently simplify the wrist joint to only one joint, and which, based on the design, we believe it's a radiocarpal joint. Data provided here can be used to design new wrist replacements that can mimic the actual and complex relationship between these bones. Let's move on and look at the total wrist arthroplasty biomechanics from the three primary outcomes. First, I wanted to determine the center of rotation of the wrist and compare it to total wrist arthroplasty. I wanted to evaluate different patterns with the hope of providing more information to design better implants. Second, I wanted to develop methods to define the alignment of total wrist arthroplasty, which is lacking in the literature, and I wanted to determine their influence on clinical and functional outcomes. And lastly, I wanted to look at the contact pattern of total wrist arthroplasty and see if there are potential regions that cause problem during the movement. To answer these questions, we designed an experiment to study both the implant and healthy wrists in vivo. We recruited 2 cohorts of healthy people and patients with total wrist arthroplasty. We used CT scanning to create 3D bone models and implants, and we wanted the density-based models for our biplane video radiography experiment, because we use these density models to track the wrist movement in the radiographs. So we enrolled 6 subjects with total wrist arthroplasty and 10 subjects with the healthy wrist. And in this study, we only look at one of the implant designs, the Freedom Arthroplasty, which is one of the newer generations, and it has a good clinical outcomes in the literature. So we acquired their CT scans of the wrist of our subjects in the neutral posture, and this was on the dominant hand of our healthy cohort and both hands of our TWA population. After acquiring the 3 CT scans by segmenting them, the bones and the implants, we calculate many of their properties as their position in the neutral posture. These segmented regions are then transformed into 3D models, and the bone density image volumes are also exported because we need them for further processing in biplane video radiography. And at the end of this stage, for the healthy wrist, we have third metacarpal, radius, and capitate surface models. And for the TWA cohort, we get the bones and the implants. We also use a 3D scanner to modify the model of the radial component and get the model of the polyethylene cap. To calculate the motion, we use a method called biplane video radiography, or BVR. In this method, we capture 2 X-ray images of the wrist while the subjects move the wrist in the field of view. And using 2 images and the density-based models, we track the bones and implants to calculate the motion. We performed this experiment at the X-ray facility at Braun, and here you see the 2 X-ray sources. The capture rate is 200 Hertz, and the field of view is calibrated. We ask our subjects to perform various tasks. One of them is picture pouring. The subject holds a picture, move it up, and perform a pouring task. Another is a hammering task. We ask our subject to perform hammering with a virtual nail without hitting it. This approximates the dart thrower's path. And we also have 3 range of motion tasks: flexion extension, radial lunar deviation, and circumduction. We control their pace in all tasks by a metronome that beats 90 beats per minute, and all tasks are captured for 2 seconds. BVR's main tracking algorithm uses digitally reconstructed radiograph, or DRRs, and DRRs are created by a raycasting approach based on the density of the bones from the CT scan. They are basically a simulated radiograph from a model. Then we enhance the image features for the DRRs and X-ray images using filters like Gaussian or Sobel. And we basically want to see the same features, image features, in both the DRR and X-ray. And using 3D image matching algorithms, the software finds the optimized position in 3 dimensions. In this project, I used Autoscoper, which is one of the software that I developed in the past few years. And right now, Autoscoper uses particle swarm optimization method. And yeah, so I just saw the message. Yeah, that's fine with me. If whenever we get kicked out, we can come back in. Thank you for letting me know. So let's look at an example of some data that is acquired based on this method. In the top left, you see one of our subjects moving his wrist in flexion extension within the field of view. On the top right, you see the implants tracked or matched in the video radiograph. And on the bottom right, you see mathematically we fix the radial component, and because we want to look at the motion of the carpal component. And at the bottom left, you see the optical motion capture data. We captured those data to assess the soft tissue artifact. I'm not going to talk about it during this talk. And lastly, in the middle, you see the actual motion that the implant took in vivo. So we measured the accuracy of our BVR system actually in 2 pilot studies. First, we used 6 healthy cadaveric wrists and compared the BVR results to gold standard optical motion capture. So optical motion capture can be considered as gold standard when the markers are directly attached to the bones. And because this was an in vitro study, we were able to do that. So we found the bias between BVR and optical motion capture is sub-millimeter and sub-degree, and 95% limit of agreement between the methods was less than 1.5 degree and 1.4 millimeter in translation. Similarly, we measured the BVR accuracy on 1 implanted wrist. We found the bias between BVR and optical motion capture is sub-millimeter and sub-degree, with a limit of agreement that was less than 1 degree and 0.9 millimeter in translation. To define the motion for both cohorts, we need a consistent coordinate system. We defined the coordinate system for each bone based on their anatomical landmarks and geometry. Similarly for the implant components, for the sake of time, I won't describe them in detail, but we have shown the robustness and consistency of our method to calculate the coordinate systems. And to describe the wrist motion, we use the posture of the third metacarpal relative to the radius for both cohorts. Implants are tracked by the components, so we transform their kinematics information to the bone's coordinate system in post-processing. To describe the motion, I use the helical axis of motion parameters, or HAM. And HAM describes the motion by a screw axis on the space and the rotation about and translation along that axis. And also, I forgot to mention that the neutral posture is calculated based on the position of the third metacarpal and radius coordinate system when the flexion extension and radial ulnar deviation are aligned. This is an approximation for when the back of the hand and forearm are aligned in one plane. So we use this experiment to evaluate 3 primary outcomes. To compare the kinematics, the center of rotation is widely used in the knee and hip literature, and we want to use that to create a data-driven approach for designing a new total wrist arthroplasty in the future, and to understand the in vivo motion better. So I have an example here for the overly simplified elbow joint. The center of rotation, or its axis of rotation, goes through your elbow, which means if you want to replace it, you have to design a joint that mimics the same behavior. And a hinge joint can do that perfectly. For the wrist, previous studies have showed the center of rotation is located at the proximal side of the capitate with minimal distal proximal or up and down movement. But none of these studies have looked at the overall behavior of the center of rotation and across various movements. For the implant design, based on our understanding of how the articulation should move, we can hypothesize a center of rotation location. Ellipsoidal joints is basically a two spherical rotation. For flexion extension, if you look at the side view of the image, the implant, the articulation is about the smaller curvature. And for radial ulnar deviation, the right picture, this articulation should happen about the center of the larger curvature. So we similarly hypothesize that our in vivo TWA center of rotation will be at these locations. So our goal here was to describe the pattern of center of rotation behavior for the wrist and total wrist arthroplasty. In this figure, you see the axis of rotation, location, and orientation for three different postures. These are the for our implant cohort. So we are gonna get kicked out soon.
Yeah, to give you an update, it's about 2 minutes. So keep going. When it punts us, the recording will stop, and then we can just log back in. We'll start up.
Okay, with the same link?
Yeah, should work. Message me if it doesn't.
Awesome, thank you. So to determine the center of rotation, we need to intersect the axis of rotation with the anatomical planes of the bones. And we do this on sagittal and coronal planes. Sagittal planes on the left and coronal planes on the right. Here I'm showing the center of rotation on the capitate for the healthy wrist, and the area is a standard deviation of that specific point. If we look at the left or the side view, the flexion extension center of rotation was located on the proximal pole of the capitate, and the flexion center of rotation was located more volar for the extension center of rotation. In the right picture, or the volar view of the capitate, the radial ulnar deviation center of rotation was located around mid-capitate, and the ulnar deviation was significantly ulnar to the radial center of rotation. And for a statistical analysis, we use generalized linear models. Similar to the healthy wrist, I'm showing the replaced wrist center of rotation results. Center of curvatures are shown as black dots, and the standard deviation of center of rotation in both directions are shown as colored ellipses. The replaced wrist had a center of rotation located slightly distal to the center of curvature for flexion extension in the left view, and center of rotation was slightly proximal to the center of curvature for radial ulnar deviation, as you see on the right picture. There weren't any other